But without further ado, I'd like to thank the St George's team who kindly hosting tonight's Journal Club, and I'll pass it over to Joshua Ong, who's been leading the organisation this evening. So, Joshua, over to you. Thank you.
Thank you, Bharat. So I'm the current Upper Limb Fellow under the mentorship of our panelists, which is Mr. Yemi Pierce and Mr. Magnus Ananda. And Professor Duncan Tennant is having some IT issues, but he will join us very soon. We have our trainee, our department physiotherapist is Simon Nicole. He's a specialist physiotherapist. He's one of the speakers. And our trainees is Jawad Salim and Patrick Lancaster. We should start off the first presentation. And that is a paper from Germany. It's the long-term outcomes of a contemporary arthroscopic Bankart repair technique in patients with traumatic anterior shoulder instability, a minimum of 10-year follow-up. So Jawad Salam is going to present that for us. Thank you.
Thank you, Joshua. And I hope that shows. So good evening, everyone. As Joshua mentioned, my name is Jawad. I'm one of the orthopaedic registrars on the South West London rotation. So I'm going to be presenting this paper by Doe et al. Entitled The Long-Term Outcomes of a Contemporary Arthroscopic Bankart Repair Technique in Patients with Traumatic Anterior Shoulder Instability. And as mentioned, it's a minimum 10-year follow-up. It was published in the Journal of the American Journal of Sports Medicine, and that was this year. So the authors purport that the current reported literature failure rate of Bankart repairs is as high as 37%, but they hypothesize this is slightly related to this being many retrospective case series involving historical techniques, such as suture tack techniques. So their aims were to evaluate the long-term clinical outcome of Bankart repairs using contemporary techniques, and this was done in patients with traumatic anterior instability. They also aim to assess possible risk factors for recurrent instability in the population. So in terms of the methods, it was a retrospective case series. It was a single-center study involving 6 surgeons. It involved patients with only anterior shoulder instability who underwent this contemporary surgical technique, which we'll discuss. The primary outcome was recurrent instability, so that be dislocation or subluxation, and the secondary outcomes were shoulder function and sports activity. They did have a number of exclusion criteria, so that involved patients with previous surgery, any additional procedures performed at the time of Bankart repair, any patients with multi-directional instability, and then patients with significant bone loss, so that'd be a glenoid defect of more than 20%, and also patients with off-track Hill-Sachs lesions. So in terms of their surgical method, patients were operated on in the lateral position. 4 different suture anchors were used, and there was a standardized post-op rehab protocol. So in terms of their results, 635 patients were analysed, with 321 being eligible for inclusion. And as you can see there on the right, on the flow chart, there are a number of patients who were excluded, who were lost to follow-up. So that was 139 patients. In terms of the patient characteristics, we can see here the mean follow-up was nearly 14 years. The patients, 25% of patients were deemed to have a hyperlax shoulder, according to their Gagey examination. And the Baton score was in 10% of patients was over 4. The majority of patients had recurrent shoulder instability, and their age at surgery was 27. The majority of patients did not have any glenoid defect, and the time to surgery was about a year. So the authors found that they had their population had recurrent instability in nearly 21% of patients, 82% of which was traumatic. There was a close to 10% revision rate, and then risk factors they found for recurrent instability were patients with a younger age, so particularly those younger than 20. They did not find a statistically significant difference between outcomes in terms of reinstability between first time and recurrent dissecators, but clearly there you can see there's a 10% increase in the rate of reinstability in patients with recurrent desiccation prior to Bankart surgery. They did note that patients without recurrent instability had significantly better shoulder outcome scores and apprehension test results compared to patients who had recurrent reinstability, but no statistically significant difference was found between sports activity levels preoperatively and postoperatively across their cohort. So in terms of discussion points, this study reports that it has the second lowest reported failure rate at that time point, so with that length of follow-up, but this is close to 21%. And as mentioned, they stratified patients, i.e. their patient cohort were only managed with contemporary techniques. They note that younger patients were at higher risk of reinstability. There was a lower failure rate in first-time dissecators, and sports activity remains high despite the rate of reinstability postoperatively. What do I think were some of the benefits of this study? Again, there are a number of retrospective case series out there looking at instability. This is one of probably a few that are specifically looking at contemporary techniques, and particularly with this long-term, nearly 14-year mean follow-up period, which is a long time. Looking at the literature, the majority of studies are between sort of 3 and 5 years. I think it gives surgeons and patients a guide as to what they might expect in terms of their long-term outcomes. And I think it further evidences some of our known concepts relating to reinstability, i.e. patients who are younger have a higher rate of reinstability. I think there was an interesting take on the participation in sport across cohort, looking at nearly 20% rate of reinstability, yet the participation in sport remained constant throughout, either pre-op and post-operatively. What were some of the limitations? We know this is a single center study, although I think the operative technique is probably generalizable. There was a 43% loss to follow-up, so we know that could lead to attrition bias, and whether that's due to patients being very happy and not coming back, or patients who have gone elsewhere due to reinstability is unknown. This is, as we know, level 4 data. I'm not sure it contributes anything particularly new. I think it further reinforces our evidence base, but it's useful in that aspect. And I think when it talks about glenoid bone loss, they've had a cutoff of 20%, but we know more recent studies may outline that glenoid bone loss levels of up to 13.5% may be acceptable when thinking about soft tissue versus bony stabilization, although there is obviously discrepancy in management of that. And how they assessed on-track versus off-track shoulders varied throughout the population cohort between MRI, CT, and through arthroscopy. So that's the paper.
Thank you, John. So in terms of, we usually would do a poll, but I think the poll is not working. But if the the participants can post any questions they would like to ask, and also for the poll, we were interested in what how the participants deal with their instability patients, especially with that tracking question in terms of how would you usually in your trust calculate the tracking? Do you use the CT calculations? That's something like the Di Giacomo paper, or MRI calculation, which is by Giftopoulos. Do you augment it with an arthroscopic evaluation? That means putting the shoulder in the position of 90 abduction and external rotation arthroscopically. Has anyone had any experience in AI predictions, which the latest program called GlenTrack? It's a free online program that can calculate the tracking for you? Or do you rely on your MSK radiologist to include it in the report? Or also if there's you don't calculate any tracking in your management, if you could try and give us some of the insight in your chat, that would be great. Otherwise, questions, like for what I can think of is, John, what do you think about this magic number in terms of the anchors? They mentioned is contemporary. Is there, what do you think about positioning of the anchors? Is it relevant? Is the spread of the anchors so that it doesn't cause any postage stamping and fracture propagation in terms of the amount of shift? Is there any kind of quantification of the capsular shift? So if you could give your opinion on that, and then we can pass it to the panel to see if they can give their insights on that.
I think the paper itself didn't necessarily delve into those details. I think they focus more on the quantity of suture anchors and mentioned that historical techniques have used maybe 1, 2, and then sometimes 3. So they were very specific on, looking at 3 anchors. So they didn't necessarily delve into the degree of shift, but as you mentioned, I think that's often deemed intraoperatively as to when you're happy, whether the degree of shift or whether you need more anchors based on the degree of injury. So yeah, in terms of the paper, I think they focus more on the number of anchors rather than the quality necessarily, and delving into that. I wonder if any of the senior faculty may have a different opinion or got any comments.
Yeah, the number of anchors has sort of crept into normal practice now. I can't remember the paper, but there was a paper that showed a significant failure rate with less than 3 anchors, and that seems to be received wisdom. But I completely agree with Jared. The fundamental principles of stabilization surgery are about what you do with the capsule, as well as the stability of your repair. And modern anchors are pretty damn good these days. So the chances of failure of your repair, I think, are unlikely to be related to the number of anchors. And really, the key thing is what you're trying to achieve biomechanically, as well as neurosensorily with the capsule. So I'm not sure that 3 anchors is a sort of as a golden number, but it has become an accepted number in the literature.
There doesn't seem to be any questions from the participants. So in terms of this, just going back to this paper itself, the recurrence rate is very high, and that's about 20.9%. But I think they include both subluxations and redislocations. Is there any kind of cutoff in terms of, is it just subjective subluxations, self-relocation, or habitual? What do you think, Jawad?
I believe it's more subjective, and that's, as you say, one of the reasons they think that their rate of reinstability is higher, because a number of previous papers, or a lot of the literature, doesn't include subluxation. It counts pure dislocation as their reinstability rate. So yeah, I think that's potentially a reason why it's higher. But I think also the fact that it's a long-term follow-up, 14 years is quite a long time, and the majority of their patients suffered trauma in that time. So I don't think that's probably something we wouldn't necessarily expect.
Yeah, because they are still letting the patients go back to sports, and they are continuing with their sports and their activities, but they report this recurrence rate. And I think there was a number that they threw out was, I think, in 39.5% occurred in the first 2 years. So I'm just wondering, is there any temporal difference in terms of our patients not going back to sport that early, in terms of rehab, confidence, and also how to assess their stability and that will be in the third paper, paper we're talking about. But I'm just wondering, Mr. Pierce, what do you think in terms of, are these failures after 2 years? Are they just because they are allowed to go back to contact sports? Because I would sometimes tell patients you need to wait at least 6 months before you go back to contact sports. So do you think this is like a selection bias of why the failure rate is lower in the first 2 years compared to the rest of the next 8 years onwards?
Difficult to answer that one, but what I wanted to do is just wind back a little bit. For me, there are a couple of significant issues with this paper based around the heterogeneous nature of the population that they are investigating. So if you look at the table, there's a table that looks at scapular dyskinesia and the presence of scapular dyskinesia both afterwards, and I think they do it preoperatively as well. Now, if you go by the sort of traditional sort of Stanmore categorization of instability, which does have issues, but is quite a good sort of is quite a good framework with which to work. Scapular dyskinesia falls under the muscle patterning instability group, and you can have muscle patterning instability secondary to either type 1 or type 2 instability as well. But if it's secondary to type 1 instability, you would expect that having fixed the labral lesion and the instability caused by traumatic dislocation, scapular dyskinesia should improve. And they have a very high level of scapular dyskinesia continuing, and that's either because the diagnosis is wrong or they haven't rehabilitated adequately, and that's going to contribute to their outcome. So that's quite important. The second thing is bone loss. There's quite a high number of people who had bone loss, and as Jared said, 20% is not what everyone uses, and there are lots of papers that show that threshold bone loss is probably lower than that in terms of failure rate and not addressing the bone loss. Interestingly, if you look at I can't remember which table it is, but if you look at their table where they're looking at odds ratios in terms of the factors that influence failure, although glenoid defect is not statistically significant, it has the biggest effect size. So the only thing that's statistically significant is age, but the effect size of age is relatively small compared to the effect size of glenoid. So it might just be a type 2 error. They haven't got enough patients in it to detect statistical significance. And so the real problem I find with this paper is that the patient group is incredibly heterogeneous, and sort of trying to work out whether things have failed because people are hypermobile, and we know hypermobility has a higher incidence of failure, or there was underlying muscle patterning instability, or actually they had a threshold bone loss and that wasn't addressed, is really difficult to pick out.
If it's the age that is statistically significant, does the long-term follow-up patients will change in age too, so they should be getting more and more stiffer and stable, right? Like, do you think so? Yeah.
But also younger patients are more likely to return to hazardous sports than older patients. So it's multifactorial. It's very difficult to be certain on that.
Okay. I think
Amal's got a question.
Hi. Nice presentation, Jawad. I have a quick question and a comment. It would appear, it's a good thing that this study has shown that if a stabilization is undertaken for a first-time dislocator, and then you compare it with the cohort of those where stabilization was done for recurrence of dislocations, then those who had the shoulder stabilized after a first dislocation did better. Is that correct? Is that what the paper showed?
Yeah, so it showed that there was, I can't remember the number, I think it's 12 versus 24%, I think, something like
Yeah,
that.
but then it was not statistically
Yes.
significant, which
Yeah.
I find quite interesting, because this whole debate now and this discussion we currently have about stabilizing the first time dislocator and not allowing them to dislocate recurrently because of the perceived issues with a inferior outcome. But here we are looking at a fairly long follow-up period using contemporaneous techniques, and we are still finding, yes, there is a difference, but it doesn't reach clinical significance. So uh, it does still bring back into the head, you kind of bring back into the focus the whole issue about stabilizing first time dislocators. I don't know what others think on the panel, what your thoughts are with this, and if stabilizing the first time dislocator is now becoming part of your routine practice.
Definitely not part of my routine practice.
Yes.
I'm quite conservative. But it's interesting. I mean, they actually acknowledge the one of the problems with that, in that if you have, although their average age was mid-20s, we know that the older you are, the less likely you are to have recurrent instability. So everyone in the lower risk group who have a first time dislocation and then have surgery would have done well anyway.
Mm.
Do you see? And so the first time dislocated group who have surgery, almost by definition, are going to do better than the recurrent dislocating group, just because that contains a whole bunch of people who would have been stable whether you operated on them or not.
Yes. They're a
And so,
self-selected group in a way.
well, sort of, yeah.
Yeah.
So it's I don't think you can read too much into that, and it doesn't reach statistical significance anyway. So I don't think it's something that's going to massively sort of push people towards fixing first time dislocators, unless that's your practice anyway.
Yeah, no, that's yeah, I agree too. Good. I think should we move on to the next speaker?
There are a couple of questions on the chat. I don't know,
Yeah, go
Josh,
on.
if we've got time or you want to move on to the next.
I think we can quickly address questions.
Yeah, I can't see the questions.
Okay, I can read them out. One question was do we know what the criteria for doing the surgery on the first time dislocations was?
I don't think it clarified that.
Okay. And then another question was a technical kind of tip to the panel. The position of the most inferior anchor is obviously critical to recreating the IJHL. Do the panel have any tips on how to get the anchor in the best position? Do you aim for the 5 o'clock position?
Difficult question. I sort of, what I personally do is I gauge the shift. So I gauge the tension in the inferior glenohumeral ligament and the inferior capsule. And I use a knotless technique where you can place your sutures into the IGHL and the inferior capsule. And then you can pull up on that suture to see what kind of tension you get in the tissues. And the advantage of that technique is that the inferior anchor then the position of the inferior anchor becomes obsolete, because you can increase tension if you want to by either bringing your anchor closer onto the glenoid face or bringing it higher up the glenoid face. So it gives you full flexibility without committing you. If you put your anchor at 530, say, and then you take a relatively shallow bite, you're going to get a minimal shift. You put your anchor at 5 o'clock and you take a huge bite, you're going to get you're going to really tension that, and sometimes you tension it so much that your sutures are under a huge amount of tension. So technically, how I do it is put my sutures in, gauge where I want my shift, and then put my anchor in using a push lock anchor where the tension takes me.
Thank you. I think Josh can probably move on now.
Yes, it's the question that the criteria is quite relevant, and the second paper actually can possibly answer that. So Joe, we still can't do any poll questions yet, no? If we can't, then we move on to the second paper. So Patrick Lancaster is going to present. So I think we're going to go for the Pittsburgh instability tool. I'll let you do the introduction then.
Yeah, thanks very much, Josh. My slides appearing, everything okay?
Yes.
Yeah, great. So yeah, my name's Patrick. I'm one of the trainees on the South West London rotation. I'm presenting the Pittsburgh instability tool, which was obviously a study out of America, which looked at predicting outcomes after topic anterior shoulder stabilization in patients with subcritical bone loss. So the purpose of this study were that the patients were aged 14 to 40 with on-track lesions and subcritical bone loss, which, similar to Jawad's paper, they set the criteria at 20% as subcritical bone loss, who underwent stabilization for anterior stability. So these is really looking at those, obviously the off-track lesions are the ones you would add something to your standard Bankart repair. You would add something like a remplissage. Where this is looking at those on-track lesions where you may consider doing a Bankart repair alone. And it's trying to identify the patients that are at high risk of failure of just having a Bankart repair and trying to identify those patients pre-op. So you could do something else intraoperative to try and reduce that risk. In this case, do the remplissage. So this was a retrospective review of prospectively collected data. They identified 1,600 patients initially, but then once they removed the non-anterior stabilizations, they were left with 700. They did have quite a rigid exclusion criteria, including previous ipsilateral shoulder surgery, uncontrolled seizures, a fracture, if they had multidirectional instability, any connective tissue disease, and they had to have had an MRI within 6 months of the operative procedure, which obviously we work in the NHS and that's quite challenging a lot of the time, but over there, maybe less so. And all surgeries were performed in the same institution by 5 fellowship-trained surgeons. So in the end, they were left with 170 patients, and it was a minimum 2-year follow-up in this case. So 170 patients, 116 underwent a Bankart repair alone, and 54 had the addition of a remplissage. That choice pre-op was purely the surgeon's choice. These were not randomized, and so it was just the surgeon's decision whether or not they wanted to do the remplissage on the patient or not. 13 patients had recurrent dislocations, 9 in the Bankart repair alone group, and 4 in those who had the remplissage as well, and 20 patients had recurrent subluxations. And similar to what was discussed in the previous paper, this was subjective subluxation, so patients reporting feeling instability. So the way they reported this was the rate of recurrent instability in Bankart repair alone was 5.2 per 100 person years, whereas if you add a remplissage, it was 2.3 per 100 person years. They dug deeper into this data and looked at all the characteristics, and then performed a multivariate survival analysis and the user hazard ratios from this to create the Pittsburgh instability tool, which is a sort of interesting thing about this paper and what we're going to get on to discuss. So these were the factors that they found from their multivariate survival analysis to be most associated with recurrent instability, sorry, not just dislocation, but recurrent instability post-operatively. So a lot of them, similar to again, the previous paper, is kind of things you'd expect. So patient age, if you're younger, you're more likely to have recurrent instability. You're a contact athlete. If you have glenoid bone loss, so obviously subcritical, what they've defined as 20%, but increasing values up to that. They did an EUA under anesthesia, and they do lay out in the paper how they did the EUA. And if you were increased laxity, then that made you increase risk. This distance to dislocation, so obviously that's how close your Hill-Sachs. It's an off-track, sorry, it's an on-track lesion, but it's close. The medial aspect of the Hill-Sachs is quite close to the glenoid tract. So these have been shown to be higher risk. So again, it found that that was the case in this study. Interestingly, after the previous discussion, it did found that higher number of instability events preoperatively led to you having an increased risk of dislocation postoperatively, and from their work, they found that was statistically significant. And then they created this score where if you score 0 to 3, you're low risk, and essentially that means from their data that you've got about a 2% chance of recurrent dislocation. Moderate risk put you about 8%. High risk put you at 18%, and extreme risk put you at 15%. And they found the addition of the remplissage reduced your score by 8 points. So really, we want everyone in that low risk category if we can, or at least in the moderate risk. And if you're adding a remplissage and they're still in high risk or extreme risk, then you need to, the paper suggests you need to start thinking about doing something else, such as a bone block procedure, obviously depending on the patient's requirements and their injury as well. So the strengths of this paper, I thought it was pretty good paper actually. It's quite well written, and it lays you out an evidence-based guide for those patients that you think, okay, it's an on-track lesion, I could just do a Bankart repair, but you are a bit worried about them. It gives you criteria you can use to say, okay, they are at higher risk of failure, and maybe I will do a remplissage in this patient. So I think that's very useful. It also did show that addition of a remplissage decreases instability postoperatively, but interestingly, not actually dislocation. The rates of dislocation were about the same in both groups. It was just that subjective instability that was decreased. As I said, it wasn't randomized, and you could obviously assume that the patients who had the remplissage addition in the first place were probably the ones at higher risk of redislocation, which is why the surgeon did it. So the limitations, well, it's obviously non-randomized retrospective study, which is a limitation with a very small, well, sorry, not very small, relatively small patient cohort. And it did have a very narrow inclusion criteria. So with 700 anterior stabilizations, they only got down to about 170 that they could actually get all the data on. So whilst it may be a useful score, it's only useful in quite a specific criteria of patients. For me, the biggest limitation was the lack of PROMs in the patients, especially the ones they did the remplissage on, because they may have had less subjective instability, but if they couldn't move their shoulder, then they won't be very happy, even if it doesn't feel unstable. So, so that for me was kind of the biggest thing. And they do actually identify that in their paper as well. But that for me was the biggest thing. You need a bigger randomized trial to test this, and you need patient-reported outcomes to know if adding that remplissage is actually the most beneficial thing to do. But ultimately, I thought it was an interesting study. It was a good study to discuss, and it does give you a bit of a guide when you're looking at these patients you think are at higher risk of dislocation, and when you might want to add anything further. Thank you very much. I will stop sharing my screen.
Thank you, Patrick.
Thanks, Jeff.
Are there any questions from the attendees? Just wait a while. There was supposed to be a poll on to see what in your practice, what would you do in terms of assessing hyperlaxity? Because we routinely do the Baton score, but there are the paper suggests a examination under anesthesia. Not sure who else commonly practices that. And then there are other scoring systems like the Brighton score, and one of the French hospitals have another score. So I'm just wondering what the attendees do, who else in the panel has any other assessments for hyperlaxity to add to this Pittsburgh score.
Well, in terms of assessing hyperlaxity, I tend to rely quite heavily on Gaget's test and looking at glenohumeral hyperabduction, but also glenohumeral hyperexternal rotation beyond 90 degrees, as well as a sulcus sign, usually on the contralateral shoulder, because you can have obviously acquired traumatic increased laxity, but that's what I tend to use. And there is pretty good evidence that you can have focal shoulder hypermobility without necessarily having a high global Bateman score.
Okay. There's a question there. In high-risk groups, why bone block was not considered and only anterior Bankart repair with remplissage? Why was that the only thing that was undertaken? Any indication in the paper? So I think the question was, what was the indications for proceeding for a bone block procedure?
Well, they were just looking at anterior stabilizations, so they excluded bone block procedures from it, and they've obviously it's patients with subcritical bone loss with a on-track lesion, so the ones you may not do a bony procedure for, so that's and they're sort of trying to identify the patients that maybe you do need to do one for. So if using that Pittsburgh tool, you've got a very high risk patient, you add in a remplissage and the score's still 15 or 12, then that's when you may think of doing, and then they suggest in the paper that's when you may think of doing a bone block procedure, or obviously if they've got 30% glenoid bone loss and these sorts of things. But I think it was to try and identify those patients where this may not be enough alone, and you can add that, or identify the patients where just a Bankart repair may not be alone and you add the remplissage. Obviously, the steps to what you do in terms of increasing the stability, but obviously bigger operations with potentially increased risks as well.
Yeah, this paper already excluded the bone loss group. About 20% were excluded already. The interesting one was the near track. Their definition of near track. So they're saying distance to dislocation is less than 10 millimeters.
Yeah.
So they are assessing what we were considering the humeral track rather than the glenoid track instead. So the humerus is the one that's moving and tracking along. And Mr. Pierce, you've got a very nice kind of analogy for it. And do you want to share that?
You put me on the spot here. I'm not sure I do, because
it is relevant for this. It's definitely relevant for this paper,
As I explained to you, I mean, I still struggle with getting my head around the actual concept of the glenoid track conceptually, because it is just sort of back to front. The track is on the humerus rather than on the glenoid as described, which is just the wrong way around. Because if you thought of the track as the glenoid, the thing that the ball runs on, 10 millimeters is actually quite significant. That's the equivalent of about 30% bone loss, because your average glenoid is 35 millimeters. So what they call a near off-track lesion is quite a wide wide part of your track. But I mean, I thought it was a really good paper. As Paddy said, it's they've looked at this is a retrospective look at their practice, and what they've done is they've tried to pick out predictors on the basis of their failure rates on their practice, and the statistics they've applied are incomprehensible. I'm afraid they're really quite challenging, and I just have to take them at their word when they say these are the numbers they've got. But if we believe them, I think it's a fairly robust study. The one thing I was going to pick out was something Paddy mentioned as well, which is the negative side of doing a remplissage. There is evidence of loss of external rotation, which is probably only about 10 degrees loss of external rotation on average. So it's not huge, and the morbidity associated with it is actually relatively low. But what they've shown is that if you've got patients with very high risk, you can reduce that risk significantly by adding remplissage, but your numbers to treat are sort of 4-1. So you basically need to do 3 unnecessary remplissages to prevent an instability occurrence in every 4 patients. So you might be over treating, but I think the chances of you doing harm to the people you're over treating by doing a remplissage is actually relatively low, which also goes into Paddy's point, which is that it would be great to have PROMs, because the only way you can be reassured about that is to know that the patient-related outcome measures aren't adversely affected by over-treating. But on the whole, I thought it was a good paper.
Okay. There are no other questions from the attendees.
No, nothing's come up. Sure, they can always add it in for
Yeah.
after.
Okay. So we'll move on to our third paper. So Simon Nicol is going to present on the Margie Olds paper, reliability of a shoulder arm return to sport test battery.
Thanks, Josh. I'll share my screen. Okay, can you see that? Okay.
No.
Oh,
And while we're waiting, there was supposed to be another poll for the attendees to say, can you share your post-stabilization restrictions? So we're saying, do you choose time, temporal, like 4 to 6 months? Do you choose clinical assessment, the apprehension test and strength test? Do you do functional benchmarking, dynamic stability or proprioception? Do you use a test battery, like we're going to talk about, like this open or closed chain test battery? Or are you? Is there any sports-specific rehabilitation and restrictions, such as overhead athletes or contact athletes? If you want to add it to the Q&A, that'd be great. Otherwise, we'll move on to this. Yes, thank you, Sam.
thank you, Josh. Okay, yeah, so I'm going to present the Margie Olds paper, as Josh has mentioned, about the reliability of shoulder and arm return to sport test battery. This is the full reference for you if you want to pick up on it later, if you haven't had a chance to read the paper. So reason why they've done this, the background to the study really, is that often the decision when an athlete can return to their chosen sport is difficult and complex to decide, and it could be held back due to a lack of reliable or valid physical performance tests. They, in their paper, quote that there is a recurrent rate of around about 50%, highlighting a need to improve the assessment tool. So they sort of suggest that the current tools before this paper was written were difficult and expensive to perform clinically. They don't have psychometric properties, although I couldn't find whether or not they actually recorded any psychometric properties through this paper. It doesn't seem as though they did. They lack normative data and cutoff values. They don't necessarily actually represent the diverse requirements of various sports, but that is a problem and difficult, as we'll come on to. They often focus on isolated efforts rather than sustained performance. So a one-off maximal effort, or a one-off maximal strength test or a power test, rather than testing over time. And again, they only measure one single construct, so they may just like test power, time, or range of movement, but not the full battery as described by Olds in this paper. So they aims were really to investigate the reliability and the responsiveness of their self-named shoulder arm return to sport SARTS test battery. And they wanted to establish whether or not this was reliable and responsible, and also whether there was any difference between limbs. So is there limb asymmetry or symmetry? They hypothesized that there would be significant familiarization between the first time point, and then there would be good reliability, or good to excellent reliability, by the second to third time points. Their method of recruitment was based around a university body in Midwest University in America. 83 people signed up to have a go at the test or inquired about it, and 45 consented to the study, of which only 40 patients made it through. 40 subjects made it through. Quite rather conveniently, they were 20 men and 20 women. They were excluded on the basis of any recent arm, shoulder, back, or neck injury in the last 12 months, any previous shoulder or spinal surgery, upper limb fractures, long-standing neck pain, neurological symptoms, or any low back, hip, or knee pain, because some of the testing required the ability to use the whole body. With this body of students, there's no mention of what level or what type of sports they participated in, whether they be collision sports, whether they be field sports or land-based or water-based sports. They don't mention the level of participation that they were at, so whether or not they were high-level collegiate or whether they're just recreational athletes. Interestingly, also, all of them were right-handed, which doesn't really necessarily fully fit, as you'd expect some to be left-handers out of that population, considering the normal population is hypothesized that there's between 10 to 11% of people are left-handed. So you would expect 2 to maybe 4 of these being left-handers. With regards to the scoring here, this is the only thing, the Penn score is the only thing I could find where perhaps they are talking about psychometric data, but that was only one item of satisfaction. The rest is around pain and function, so it doesn't really seem to fit with what they're already proposing they need to do. The other shoulder activity score they use, which might have some psychometric data in, they failed to tell you what this is. So I'm unable to comment on what these scores actually mean. So the study design was a test retest of the SARTS battery of tests at 3 time points, which were 1 week apart. They had 3 testers, one of which was perceived expert. I put it in inverted commas because they've described themselves as the expert with 25 years or more experience as a physio, but they don't explain what their background in physio has been, although I believe Marjorie Oles is involved with most rugby players within New Zealand that play at professional level. So she obviously has quite good experience. And 2 novice athletic trainers, which are the master's level of sports rehabilitators. So they're the people that do all the taping, all the kind of rehabilitation-based exercises with sports participants, but they've only had a year of experience as postgraduate. The SARTS tests consist of 8 tests, 4 of which are open chain, so ball abduction, external rotation using a 3 kilogram medicine ball, drop catches using a tennis ball, ball taps using a 55 centimeter Swiss ball, which is your average sort of size Swiss ball. The overhead snatch using a 5 kilogram medicine ball. I've got a pictorial representation of these in a second. The closed chain was a push-up clap, which is a very challenging exercise for most. Line hops, again, another challenging one, but done on knees and hands. Side hold rotations, so basically a side plank, but moving through from a side plank to a plank position. And then this modified C-Quest, as I'm told it's called, the closed kinetic chain upper extremity stability test. There was one piece of randomization where the subjects started, all of them started at a different testing site, but then they alternated between open and closed chain, and they followed that same process at each 3 time points. So whatever they started on and followed the same sequence each time. So I'm not really sure what the randomization was there to do, but whether or not they were just trying to eliminate any kind of learning process from either the raters or all of the participants. It's unclear. Each of the tests were performed by 1 minute and timed. They were also videoed so that they could look at their intra and inter-rater reliability. So they watched it live and recorded with a hand clicker, and then the video was then shown to the other 2 raters once at normal speed, and then they counted to see how many, to try and measure the intra-rater reliability. They had about 1 to 2 minutes rest, depending on, but that's not recorded anywhere to know, whether it's standardized. Some may have just needed a short break, others might need it longer. So whether that sort of invalidates some of it. And they were allowed to familiarize themselves with 3 to 5 repetitions before they started recording any of the tests. So this first one, these are the open chain tests, and that's the ball abduction external rotation test at the top. So pushing out to the side, pushing above head, pushing out to the side, pushing above head. Drop catch done with a tennis ball at 90 degrees abduction and elbow flexion. Similarly with the ball taps against the wall with the gym ball, and the overhead snatch position. So reaching up from the ground, basically lifting the medicine ball up above head. The open chain ones, so the clapping press ups is obvious. The line hops, you can see there's a line in the middle and they hop either side. The side hold rotations, you can see the position that they start in and finish in. And the modified sequest is the reach across from one hand to the other, so hand taps across a fixed distance. So the development of these tests were basically deemed to be, I guess, by the rater themselves, as in demanding of athletic performance. I guess that's through experience, although it does miss some movements of dislocation, which we'll mention later. They were considered to be specific for informing the readiness and return to sport, again by the rater and the development of the SARTS battery of tests. So there may be some rater bias there. And also they sort of followed what the International Olympic Committee suggests. So the IOC want you to use minimal equipment, be inexpensive, reproducible, and easy to perform. So when they analysed the data, the intra-rater reliability was assessed across those 3 time points for all raters using this interclass correlation coefficient, and analysed using standard error of measures and minimal detectable change, and a measurement of error and responsiveness of a 90% confidence interval. The inter-rater reliability was assessed by all raters at the 2nd time point and analysed as intra-rater. My colleague who is good at statistics suggested perhaps they could have added in a Bland-Altman plot to help with these, to determine whether there's an agreement between measures for raters and rate on rate given on any given day, but this isn't included in the study. With the learning effect, there was assessment of all the raters' data at all time points and analysed using repeated measures ANOVA of mean scores, and using a Bonferrati post-hoc analysis if required, to see if there was any change over time. They don't comment if they used it. Limb symmetry was calculated from the mean scores of the expert rater only on day 2 to 3, and analysed using a paired t-test with alpha set at 0.05. They had 40 participants. They needed 30 or more to be considered a fair level of reliability. So the results would suggest that of the four tests, so the modified, sequest, and overhead snatch and line hops on the dominant and non-dominant arm, there was no significant differences across all time points. This would suggest, therefore, that you can use this straight off the bat. Post-hoc pairwise comparison highlights that all other tests required 1 testing session at least for familiarization. So with the side hole rotations and the ball abduction external rotation test and the push-up clap, one session of familiarization was needed, and then it was consistent across the other time points. With the ball taps and drop catches, there was a learning effect noted throughout every single time point. So they never really understood whether or not that person was going to get a continual learning effect from it. So probably isn't something that can be used within the battery of tests straight off the bat. with the reliability between raters across all time points, there's an excellent level of reliability achieved at 0.93 and 0.99 on the ICC, and with intra-rater reliability on days between 2 and 3 was found to be a good to excellent, between 0.78 and 0.96 on ICC. 2 of the 5 tests assessing limb symmetry, so the ball abduction, external rotation, and drop catches, highlighted significant decreased scores on the non-dominant side. So we'll talk about that a bit more further down the line, but there's a bit of difference between limb symmetry. And then there was a non-significant difference between the ball tap reps, again, on that non-dominant side to dominant. So the study's sort of self-reported strengths are that it has an endurance focus because they do this over a minute. This may, they hypothesize this may replicate more sports-specific situations and provide more information about readiness of return to sport, if perhaps potentially if this is more of a cyclic type sport, so like swimming potentially might, when you need maybe more endurance out of the shoulder. It's comprehensive testing, so it looks at multiple constructs, so strength, power, range of movement, and neuromuscular control. So they're sort of in some way fulfilling that, which was part of their criticism of other testing. Robust design because they've done it over 3 time points rather than just doing it at 1 time point, and they had an adequate sample size of 40 people, meeting the requirement for establishing fair reliability. However, on that, there's no, although they say they've covered all constructs, it's down to the kind of reader to assume which ones deal with power, which ones deal with strength, which ones deal with range of movement and neuromuscular control. They don't specify that within the paper. There's no actual reference to the SART's development either, so they don't reference them themselves. This has just come from clinical experience rather than actually being something that they've tested. However, again, my learned colleague has advised me that there was a pilot study completed to make sure that the testers were able to test reliably amongst themselves and deliver the content. But again, that isn't referenced within the paper. From a point of view of weakness, this was only performed on a healthy population, although we don't know what exactly they were, but they're deemed to be a healthy population and they didn't have any pathology. So to validate this, we probably need to do this on pathological populations. However, they would need this to be done, screened first using this tool to know what their baseline was before going to it, or if they're going to use it, if they've got a good side, they have to figure out is that their dominant or non-dominant side and figure out from there the percentage of what that has to be. So if it's a non-dominant side, they need to be approximately 90% of the dominant side. If it's the other way around, they need to be 110% to give it a fair representation due to the lack of limb symmetry. There's been they don't really fully understand what muscles are actively performing and when within the tests. Some surface EMG studies may need to be done to help understand this. The refinement of the tests needs to be considered with kind of improving the reliability of the ball taps and drop catches, because there was these learning effects over time. So how many times do they have to do that before they've fully learned? There's no inclusion of any external rotation. So again, being forced into that external rotation abduction position is often a common position of dislocation. So a test to look at that would be welcomed within this battery, and they identified that themselves. And also sex differences between the modified Sequest, potentially because of a shorter arm length, they may have to adjust the distances on that test for them so that it's a bit more of an equal playing field. They conclude then that this is a battery of potential tests that offer clinical guidance on return to sport for upper extremity injuries, but it's not necessarily convincing. 6 of the 8 tests demonstrate reliability for clinical use, with caution over the ball abduction, external rotation, aside hold rotations, and push up clap. They need 1 session for familiarization. An awareness of the need for familiarization sessions for some tests, such as the drop catch and ball tap, is required and not suitable for immediate benchmarking. Limb asymmetrical asymmetries, particularly with the ball external rotation and the drop catches. Providing context for comparing injured and uninjured and dominant and non-dominant limbs. And further research is needed to validate the battery in pathological populations with sports specifics, which I confused Jamie earlier with this, but actually within the Shoulder and Elbow Journal, somebody's already had a go at doing this. And this is what something that, again, my more learned colleague has pointed me towards. And this although it's a Delphi study of these people here, they've actually looked at it sport by sport and made some suggestions. So that may be something for further discussion. And that is it. Any questions?
Yes, there was one of the attendees raised their hand, but they didn't put anything. If you want, you can type it into the Q&A. We have very little time left, so maybe 1 or 2 questions, if there's any.
Can I make a comment?
Sure.
I think one of the problems with this paper is if you read through the introduction, it promises more than it delivers. You read it expecting a paper that is going to give you an easily performable, reliable, repeated battery of tests that requires very little additional equipment that will give you a benchmark for a return to sport. That is how they sort of set the introduction up. But actually, all this is a proof of concept. It is a proof of concept that if you have a relatively simple, easy-ish to perform group of tests that inexperienced raters can supervise, you can get reproducible data out of it. And if that's all they were trying to achieve, they have achieved that, and it's fine. You cannot get benchmark data for this for all the reasons you've said. The sports are varied, individuals are varied. There is just far too much variability. But the idea is that there is probably internal consistency within each individual doing it. And so, as a therapist working with high performing athletes or with professional athletes or whatever, I'm sure they do this anyway. If you have a battery of tests that you can do on a regular basis, one, you might be able to detect decline in performance and therefore a risk of injury. And 2, because you've got their normative data, you might be able to say you are 80% recovered after you've had rehabilitation. And what is really frustrating about this paper is they don't say any of that. And if they said that, I would say this is a fantastic paper because it's a proof of concept. You can use a battery of tests that you can teach people relatively easily. Anyone can supervise, and you can use it to chart individuals' progress throughout their playing career, before they injure themselves and after they injure themselves, to chart progress. But I think anyone who is trying to develop a standardized battery of tests with normative data and a benchmark that you have to reach to say you are safe to perform sport is probably fighting a bit of a losing battle because of the infinite variability of the human beings.
Yeah, you're absolutely right. I mean, the holy grail of return to sport is finding a battery of something that gives you some data for everybody that works, and we just haven't got there. Marjorie Oles has looked at this further down the line with amateur sports people in rugby compared to professional, and tried to, or in kind of adolescence, and tried to create normative data, normative values, but it only is relevant to that particular sport in some way. So we do I use this paper for anything? Not really in my practice. I mean, I don't see many of these sort of type people, to be honest, but it's not necessarily relevant to the instability type patients I see anyway, because I don't know what they were like before. So I haven't pre-screened them. So like you say, you have to have screened them. If you work within a sports club, it may be a useful tool to pre-screen, and then, like you say, various time points, pick it up.
I think undoubtedly that is the biggest value of something like this. If you are working with and in terms of a principle, it's quite a good principle for adolescent athletes or anyone playing sport. If you have intermittent testing, it's your biggest, with something that's reliable and reproducible, it's your biggest way of picking out dips in performance, and it's certainly what professional sports people do. Maybe we should be doing it more widely, but given that most people can't be bothered to stretch before or after exercise or warm up or warm down, it might be difficult adding a whole battery of tests to your average amateur tennis player and say, do this every sort of 6 months and see how you're doing.
Yeah, I would say my only experience of ever doing this sort of type stuff was when I was working within a rugby team, and they were semi-professional, so they had kind of a bit of a reason to do it. But since then, no. I mean, I'm as guilty as the next person of not stretching before sport.
Great. I'd like to kind of draw the Journal Club to a conclusion there, and really thank the St George's team and our three speakers. It certainly takes a lot of time and effort to put together your presentations and go through it, as you all have. So I think it's been a really interesting discussion. I'm very grateful. For attendees, there will be certificates sent out over the coming week. So keep your ears, or check your emails for those. I'd like to also just highlight that there's a OR UK Best Collaborative meeting being held on the 17th of November in Birmingham, which is still everyone has the ability to register for and attend if you're able to. It certainly looks like a great agenda. And our next Best Journal Club is planned for December, the 3rd of December, and it's going to be hosted by Derby. And that's going to be on elective elbow work. So that should be very interesting to come. And I'd certainly would really be keen for any other units that want to get involved to please contact the Best Education Committee, and we can certainly plan a date in the future for your unit to host and inform our discussion. So thank you everyone for attending, and I'll wish you a good evening.
Yes, thanks, guys. Thanks for your contributions. Some good papers and good discussions. Yeah, don't forget the OR UK meeting, 17th November. Thanks, Parag, for mentioning.